special thank you for this opportunity, and respected judges on the dais. So I'll be presenting a case of how to approach a traumatic absorbed cataract. Actually, this was a one-eyed patient. He was brought from our outreach and very reluctant to come. Actually, he had subtle trauma a long time back, waited for his vision to drop, and then he finally decided that. So decided to do SICS in this. So made 2 side ports, stained the capsule. As you can see, the capsular bag is already fused. So I did not make the tunnel right away. First I wanted to handle this fused bag. So raised the flap with the cystitome and then went ahead with the Vana scissor, trying to maneuver this bag. So first aim was to clear the visual axis in this. So I couldn't go all around with the Vana, so decided to make a scleral tunnel.
Can you pause the video, Dr. Asheesh? Yeah, any comments, Rishi?
I think, that doesn't look like there's much of cortical material also there. It looks more like fibrosis between the 2 capsules. Maybe just using a cutter and creating a large central hole would have sufficed, is what I feel.
Actually, I was to implant a rigid IOL in this case. So that's why I decided to go ahead with the scleral tunnel. Ultimately, I'll enlarge it with the cutter only at a later stage.
No, another option is that you can use, do it bimanually using intravitreal scissors and forceps. So as you cut it with the scissors, you lift it up with the forceps and cut it
bimanually.
On
the micro forceps and micro scissors.
Even a rigid lens, I think you can easily put it in the sulcus.
The tunnel, and now went ahead and approached. So once I had cut the capsule, I had planned to capture the IOL. So in fibrotic capsules, it's really difficult to capture, so you need a slightly larger opening. So at this stage, then I took the bimanual vitrectomy cutter to trim the additional rhexis margin or the fused capsular margin. There was vitreous prolapse also at this stage. Anterior vitrectomy was done. At our center, we have not started using triamcinolone as yet, but we are planning to start it. There were extensive synechia there, so release them with the repositor. Again, I tried to make the sulcus fully patent so that I could push in the lens there. Fibrous cortex there, but I couldn't get it out. Again, some amount of vitreous was there. So again inflated the sulcus and went ahead with a 3-piece IOL. Plan was to put the haptics in the sulcus and capture in the residual capsular opening. So it takes a bit of an effort as compared to the normal rhexis to capture these lenses because the margins are fibrosed. So you just have to nudge it below the residual opening, and you can see the ovalization of the opening there. So it's an endpoint that your capture has been done. So the ovalization of the capsular opening is an indication. Put in some pilocarpine to constrict the pupil. Wash the residual viscoelastic. So since this was a one-eyed patient and vitreous loss had occurred, so we always prefer to suture the tunnel in these cases. Also tend to suture the conjunctival flap over this. So at the end of the surgery, you could see a well-centered IOL.
Dr. Gaurav?
So very nicely managed. First of all, I would be just concerned about two things. One was that your capsule opening was broken at about 7-8 o'clock, and when you were doing the optic capture, I felt that it got enlarged also. So frankly, with a broken thing, and then when you do a capture of the optic, it's entirely possible that one of those haptics, especially that haptic was very close to the area where the rexus was broken, right? I mean, so, and it was not a very fibrotic rexus in that area, so it was kind of like looking very flimsy. So there's a risk that that haptic will, also follow the optic and go behind, and could dislocate at a later point also. So I might have not done the capture in this station, right? Because if my thing was absolutely intact, I would have done the capture. But if I have a broken rim and a fibrotic capsule, there's a good chance. Second, how did you, I mean, you did a good anti-vitrectomy, which is obviously very necessary, but also sometimes in such situations, if you leave viscoelastic behind the IOL, it gets trapped and can set up lots of problems like inflammation and even pressure spikes. So I'm not saying that, I mean, I'm sure you did a great job and it came out good, but for the benefit of the audience, it's also very important that whatever visco goes, please don't use a lot of viscoelastic because there will be some scleral collapse, and if you do too much of a vitrectomy, sometimes there's a lot of space, and then that retained visco will set up a situation. So I think these 2 points I wanted to just.
I think just following up on what Gaurav said, visco invariably goes in these cases through an open capsule. So before you create an optic capsule using a bimanual IA, once adequate anterior vitrectomy has been done, keep the irrigation cannula in front of the lens, go behind the lens, and just flush, and then the entire visco gets aspirated. You can actually see the strings of visco getting aspirated. Once it's cleared up, then of course you know that it's completely evacuated. And I think for a institution like yours, you did mention it, but I think that to send a message across, triamcinolone acetate is mandatory. The pupil is absolutely round and neat, so most probably there are no strands, but oftentimes I've been surprised. I think that rexus margin is clean, that the pupil is round, but then put a drop of diluted triamcinolone acetate, and you find the strands of vitreous which could have been sent right away. I think anywhere where you think you're dealing with vitreous, it's always a good idea to use as
Right.
I'll just add one more point, since you did a very good thing about putting prophylactic sutures since the patient is one-eyed. Another thing you could have added is intracameral moxifloxacin in the end, because loss of vitreous is a risk factor for endophthalmitis.
I have not put it in that, but we give in all our cases.
Okay.
Intracameral. Thank you.
So, yeah, ma'am. Okay, fine. Thank you. Thank you so much, Dr.